Hey guys, so I will be presenting my case study on a right leg arteriogram that I did with Dr. Walters. So, sorry if you guys can't see this. I've been trying to mess with it, but I think this is as good as I've gotten it. So, in the morning, our patients are instructed to go up to our ambulatory care unit where they check in and get labs drawn, x-rays if they need it. The nurses go over their medications, history, make sure they haven't ate or drank anything. So this patient had labs drawn that morning. We had ran a full panel on them. The only thing that was abnormal was their glucose was 397. They are a known diabetic that doesn't control their diabetes very well. Dr. Walters had ordered insulin at this point to kind of help control the glucose amount. The patient's allergies are metformin, warfarin, and a medication that I cannot pronounce, but it did not have any effect on any of the medications that we would be giving him during the procedure or any that would affect with anything that we would possibly prescribe after the procedure, and it was not a contrast allergy. So the patient had had previous angiograms of bilateral lower extremities. He also had previous Dopplers of bilateral lower extremities and plain films of bilateral lower extremities. So looking at the patient, their left lower leg had been amputated, and on the right side they had a they had their toes amputated off, all 5 of them. They had poor healing on the right lower extremity, which was causing possible threat of limb loss since they already had their toes gone. They were scared that they could lose more if they wouldn't get blood flow to the foot. So they had peripheral vascular disease. They've had multiple endovascular and surgical revascularizations. And on that right side, they had diminished pressure going down to the lower leg. So we were hoping to go in on the left side femoral artery. So about a week before our procedure, our nurses call the patients to go over their med list, take them off any medications that are at blood thinning properties, any supplements that have blood thinning properties, tell them what they can and can't take the morning of the procedure, kind of go over their medications with them. At that point, they tell them not to eat or drink anything after midnight, the night before the procedure, to make sure they're NPO for conscious sedation. We instruct them to go up to our ambulatory care unit where they will check in and where they will recover after the procedure. So once they're up in AMC and they've gone over everything, our interventionist will head up there, go over the procedure, consent the patient. They will have them ask any questions, have family ask any questions before. That way they can all talk about it and make sure they still want to proceed with this. So when the patient got brought downstairs, we had to move them. We placed a slider board under the patient and slid them over with 4 of us, making sure the slider board was, making sure the bed was locked, the table was not going to move on us, making sure everything was at a safe height. After we had slid them over, we made sure the board was out of the way, made sure the patient was centered so when we moved the bed they wouldn't roll off, got the patient comfortable and warm. So during our procedures, our interventionalists run the fluoro plate or the fluoro pedal. They always know when it's on, when it's off. We have a kind of minute counter and a dose counter up on our screen. And then every 5 minutes, our machine will ding at us, telling us it's been 5 minutes. This patient wasn't any isolation precautions, but we still did wear gloves when we were moving the patient. So our crash cart is located in one of our rooms, and it was in this particular room that we were doing this case in. So it was against the wall, kind of straight across from our sterile table, so we knew exactly where it was. Our oxygen is against the wall with the door, so we do use extension tubing to kind of get the oxygen all the way to the patient, and that puts it right next to where our C goes in. So we always just watch out and make sure the oxygen's not going to get ran over or destroyed. So for our sterile tray setup, when we pull the tray It comes with a cover for the II. It comes with a longer cover that we use for the monitors, so we can grab and move the monitors. And then it comes with an angio drape, which has a hole in it and covers the entire patient and the rest of the table. The ultrasound probe is dropped, so the cover is dropped. We then take the probe cover, and our partner will put jelly on the probe. We'll carefully grab it so it's sterile, and then we'll pull it down, the rest of the cover down as far as we can. They'll grab it and pull it the rest of the way, and we'll band it, put rubber bands around it so the cover can't move. And then usually we'll hemostat it to our table so it can't slide off or move, or throw a wet towel over it so it won't move. So our initial access was going to be the left femoral artery. We did have the angio drape. At this point, the patient would have been on the table, covered in warm blankets, monitor set up. We then would take and have our partner expose the area that we were going to work. So it would be left femoral artery, but we always do a bilateral prep. So we prepped both sides. So we had the right and left sides both prepped and ready in case we did have to switch sides. So after we prepped, we then put the drape down. So we put the sticky circles in the area that we wanted, and then we covered the rest of the table. We use a 21 gauge micropuncture needle, which comes in a micropuncture set, which then has a wire and a sheath with it. This particular doctor likes a 30 gauge 1.5 needle to numb up the skin and surface around it. We used a 5N6 French sheath. We also did use a torque device with our glide wire. We used a Benson wire also, and then we used a 5 French pigtail catheter and a flow switch. So we were going to try to access and go down the right side, coming from the left side, and we were going to balloon and possibly stent. We weren't sure in which order we were going to do these. Our contrast was ICV 300, which we had loaded into our power injector and then also on the table so the doctor could hand inject the contrast. So our sedation medicine is given by our RN that is involved in the procedure. They are the ones that are taking orders from the verbal orders from the doctor saying what to give the patient and how much to give the patient at what time. Our patient, because they are being sedated, is hooked up to a heart monitor, a pulse ox, and a blood pressure cuff, which run constantly during the exam. So for this particular exam, our patient was supine with their head closest to the door, so their legs were down by our kind of control station and our monitors. So for this procedure, what we started with was we were going to access the left common femoral artery. We did this by using ultrasound. So the doctor took ultrasound, found the artery, found where he would like to place it, took the lidocaine and the 30 gauge needle and started numbing up the area. After that, he then took our 21 gauge micropuncture needle and punctured the area. At that point, after we got drawback in that micropuncture needle, we took the wire that came with the micropuncture set. I gave that to him. He inserted that. At that point, he took out the needle, handed to me. I gave him the sheath. I flushed the needle and then put it into our needle holder. So at that point, after we have the sheath in, he takes that wire out. We give him our Benson wire, which is kind of a more flimsy wire that'll help him move to where he needs. At that point, we took a 5 French pigtail catheter, and we ran it over the Benson and through the sheath. At that point, we had took out the Benson wire and went in with our glide wire. So we had gotten to we were in the right common femoral artery. When we got down below the knee, we were seeing that it was occluded. We were trying to get past it a little bit, but we could not. We had then realized that we could not get to where we needed to go on the left side. We couldn't get over and past it due to the patient had a bypass, so due to that we were having problems getting over to that right side coming from the left. So then we did switch and we went for a right-sided access. We did the same process with the micropuncture needle. We kept the sheath in on the left side, so at the end of the case we would have to pull that out, but we got a new sheath. So the same process, used ultrasound to numb micropuncture needle wire, sheath, and then the Benson wire. So at that point, he decided to bump up his sheath. So after he got the 5 French sheath in, we went up to a 6 French sheath so we could get the stent and balloon down. We did end up getting to where we needed. On the right side, we were able to go down to exactly the position he wanted. So at that point, we had deployed. We got to the position we wanted. We had done runoffs on both sides kind of earlier to see exactly where we wanted to place the stent and balloon. So once he got the wire down, we used the glide wire to get down to exactly where he wanted. We grabbed a 9mm by 60mm stent and we positioned that at the right external iliac artery. After that was deployed, we then took a balloon that was 4 centimeters. It was 8mm by 4 centimeters. And then we started to dilate kind of above the stent, within the stent, and below the stent to make sure everything was pushed against. This patient did need more intervention because we were just kind of focusing at kind of the top of the problem to see if we could get blood flow back down. So Dr. Walters did want to bring this patient back and kind of work a little lower to see if we could get a little more blood flow down farther to the leg. And that was done a few weeks later. We wouldn't bring the patient back right away. So that is that part. So this is this is a picture off Google. This isn't the image that I had been part of. But this is kind of what it looked like. There was a big occlusion, a little lower, right at the bifurcation of the iliac arteries. So oh goodness, right, I don't know what I did. Okay, so kind of right, so the bifurcation, right above the bifurcation on the external side was a huge blockage, so there wasn't really any flow down past where we were seeing, oh goodness, where we were. So that's why he wanted to then go back and come back later to the lower extremities or the lower problems that we were trying to fix. So we did see a lot. I saw the femoral artery, the right common, and the right external iliac. I did say that we placed a stent and we did balloon. So after the procedure was over, we had held pressure for 45 minutes on both sides. So there was 2 techs holding pressure. After we were done holding pressure, after everything had stopped, all the blood was stopped, we slowly rolled the patient up while holding pressure on these sites while we were moving the patient, slid them over to the bed, and checked to make sure everything was good. So they were down there for a few extra minutes to make sure that the sites were still good and not bleeding or oozing, or that they weren't going to break open. After we had felt comfortable with them going back upstairs, the nurses took the patients up to AMC and kind of gave a report to the nurse. So this is kind of what we were talking with the ambulatory care nurses, is that they would be transferred up there post arteriogram. They'd be here for monitoring since they were coming out of conscious sedation, and to make sure that there would be no bleeding and that the sites would not open up. We did have the patient lay flat for up to 6 hours, no bathroom privileges. They had to be on bed rest. They really couldn't move. We want them to stay perfectly flat and perfectly still, which is difficult, but that way their sites won't open up and start bleeding again. The patient was sedated and they were coming out of that medication, so we wanted to be able to monitor them and make sure their vital signs were good and they weren't having any weird reactions coming out of it. During the procedure, since the patient had high blood sugar, we did check it periodically to make sure it was coming down, which it was. At the end, it was actually pretty normal. But we did have it checked periodically up at AMC to make sure that their blood sugar was kind of coming down and not being as high. So with this particular patient, since they've done multiple, they really had to stress to him that he needed to lay flat because he always would try to get up by himself and try to reopen the sites basically from the movement, which he ended up staying flat for all 6 hours and didn't want to move. He was just really tired and really exhausted from the procedure and everything he had gone through. So that was my case study that I did with a right arteriogram. I really hope you guys enjoyed it, and thank you very much.